Hello everyone and welcome to our module on membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis, or Mpgn, is a group of rare glomerular disorders, and the reason we're talking about Mpgn in its own video separate from the videos on nephritic and nephrotic syndrome is because Mpgn can cause either the nephritic or the nephrotic syndrome. In reality, patients who develop Mpgn present with varying degrees of renal dysfunction. It can be very mild with hematuria or proteinuria, or it can present with severe renal failure. In general, patients with Mpgn usually have some element of renal failure, meaning some increase in the BUN and creatinine. There's also usually some element of hematuria and some element of proteinuria, and the proteinuria is sometimes in the nephrotic range. Mpgn gets its name based on what you see when you perform a renal biopsy and look at the renal tissue under the microscope. The word membrano is in the name because thick basement membranes are seen in this condition. The word proliferative is in the name because in this condition there's proliferation of mesangial cells and mesangial matrix proteins. On the bottom left side of the screen is a normal glomeruli that you would see in a normal kidney. On the right side of the screen is an example of what you could see in Mpgn. Note that there are more cells, it's hypercellular. There's also lots of pink mesangial matrix proteins present in the glomeruli. This is all consistent with Mpgn. In clinical practice, patients with Mpgn present with some element of renal dysfunction. A renal biopsy is performed and the histology shows evidence of Mpgn, then the diagnosis is made, and from there treatment is determined. However, for step 1 of your boards, they are going to want you to know about the pathophysiology of the two major subtypes of Mpgn. The two major subtypes are called type 1 and type 2. Type 1 is much more common. Type 2, which is also called dense deposit disease, is much more rare. We'll talk about Mpgn type 1 first. Shown on the screen is a drawing of a glomerular capillary, including the three elements of the capillary wall. In red are the endothelial cells, in blue is the basement membrane, and in green are the podocytes. The pathophysiology of Mpgn type 1 involves subendothelial immune complex deposition. Immune complexes, which include IgG antibodies, are shown in purple in my drawing beneath the red endothelial cells. These immune complexes deposit in the subendothelial layer. This is what they're going to want you to know for step 1. And the IgG antibodies lead to complement activation and inflammation. In addition, the immune complex deposits trigger mesangial ingrowth. The mesangial ingrowth splits the basement membrane, as I've shown in this drawing on the screen. This can lead to what's known as a tram track appearance when you look at the capillary walls on light microscopy. And this tram track appearance is very common and occurs in 80% of cases of type 1 Mpgn. You can also see it in type 2, but it's much more common in type 1. Shown on the screen is a picture of the tram track appearance of glomerular capillary walls. There's an arrow pointing at one of the tram tracks. You can see how the basement membrane has been split, and the reason it's been split is because there is mesangial ingrowth triggered by those immune complexes which have deposited in the subendothelial layer of the glomerular capillaries. Because the pathophysiology involves subendothelial antibodies and immune complexes, if you perform immunofluorescence staining of renal biopsy samples, you will see a granular appearance of the kidneys when you stain for IgG and C3. Granular immunofluorescence staining is the type of result you get anytime you have a process that involves immune complex deposition in the glomeruli. Mpgn type 1 can be idiopathic, however, it is also associated with a number of other conditions. Two of them that are high yield for you to know for step 1 are that Mpgn type 1 is associated with hepatitis B and hepatitis C infection. Mpgn type 2 is the more rare form of Mpgn. It's also called dense deposit disease. And the reason it's called dense deposit disease is because electron dense deposits build up in the basement membrane. I've shown these in purple in this drawing on the slide here. The reason for these electron dense deposits is not completely understood, but it is believed that they are mediated by complement overactivation. Importantly, IgG is usually absent in cases of Mpgn type 2, so if you perform immunofluorescence staining like we described earlier, you will not see positive immunofluorescence staining for IgG in cases of Mpgn type 2. The reason this disorder is called dense deposit disease is because these dark ribbons form in the basement membrane as shown in this electron microscopy image on the screen here. And as I mentioned before, if you do immunofluorescence staining in Mpgn type 2, it will be positive for C3 because complement is heavily active in this condition, but not for IgG because this condition does not involve immune complexes. Shown on this slide is the most important feature of Mpgn type 2 for you to remember for step 1 of your boards, and that is the fact that Mpgn type 2 is associated with the C3 nephritic factor. It's also called the C3 convertase stabilizing antibody. This antibody is found in over 80% of patients who have Mpgn type 2 or dense deposit disease. Recall from immunology that C3 convertase is part of the complement system, and it activates complement via the alternative pathway. Now, normally C3 convertase is not very stable. However, in patients with Mpgn type 2, they have an antibody called the C3 nephritic factor which stabilizes C3 convertase. This leads to overactivation of the complement system, and that is believed to be the pathophysiology of Mpgn type 2 or dense deposit disease. This also leads to consumption of complement proteins, and therefore, if you test the complement system, you will find evidence of hypocomplementemia. This is because of reduced levels of C3 in the serum as a result of overactivation of the complement system. Mpgn type 2 is mostly a disease of children. Most cases happen in children 5 to 15 years old, and half of these children develop end-stage renal disease and end up on dialysis within 10 years of diagnosis. I'll finish with this summary slide. Remember that Mpgn presents with a wide spectrum of renal dysfunction that can range from mild hematuria and proteinuria all the way to the full-blown nephritic or nephrotic syndromes. A renal biopsy will show evidence of hypercellularity and thickened basement membranes. In the table on the bottom of the screen, I've summarized the key differences between Mpgn type 1 and type 2. Type 1 involves immune complex deposition in the subendothelial layer. This leads to splitting of the basement membrane and the appearance of tram tracks on light microscopy. And then finally, type 1 is associated with hepatitis B and C. Mpgn type 2 is a complement-mediated disorder. It's especially mediated by C3. It involves dense deposits in the basement membrane. You can see the dense deposits on electron microscopy. And then finally, type 2 is largely a disorder of children. And that concludes our module on Mpgn.